Okay, this is what some of these imaging look like. Classically, you can't really tell, but this is actually a skull. I think my battery is running out in my pointer here, but a skull which has some thinned areas in the skull, and we call that a pepper pot skull. But the skull is not really, and it's very common, it's not a weight-bearing part of your skeleton unless you regularly stand on your head. So we're not usually that bothered about it being a problem in any way. There's also a wrist there. You can see some small lytic lesions in that wrist. Again, that's not really a problem, but if that lytic lesion was more extensive than that, then we may need to refer to our orthopedic colleagues to put a little plate in there to prevent that from fracturing. And their other image there is a spine, and you can see the vertebra with the arrows are pointing out where there's active myeloma disease, and that can cause what's called a vertebral compression fracture of that vertebra, which can be very painful and can cause loss in height. And the dark line passing along the side is your spinal cord, and if you had an area of active myeloma that pushed outside onto the cord, you can have a symptom which we describe as spinal cord compression, and we would need to intervene quickly to give you some radiation to get rid of that myeloma deposit, to take the pressure off the cord. And symptoms of that happening would be what I might describe somebody going off their legs. If you feel altered, not a neuropathy, but an altered sensation of weakness in your legs, or weakness in bladder activity, or not being able to go to the toilet, etc. Or also you can get commonly a pain that goes in a band around your abdomen. If you have those symptoms, you need to talk to your doctor quickly, because if you have active disease there, it's very easily treated, but it needs to be treated very quickly.
Can the blood be showing that things are okay, but the bone can still be doing stuff?
Yes, good question. Can the blood be okay, but the bone still getting attacked? More commonly, you need active myeloma to cause active new harm to the bone. But what you can have is, as you get on top of the myeloma that may be within the bone can be reduced and killed off, and you can end up then with a bit of a hole there that then can fracture. So I had a gentleman actually who we're managing his myeloma at diagnosis. He's about 4 months into his treatment, and he's responded very well. His myeloma bloods are looking great. He's had a very big lowering of all his myeloma markers, and he suddenly got a rib pain. And it's likely that it's not a new deposit of myeloma in his rib, but the clearing out of myeloma cells in that area that's caused this gap in the bone that has then fractured. But more often than not, yes, you do tend to see active myeloma disease at the time of new deposits of bone problems, yeah, generally speaking. So we do some imaging to assess how much myeloma bone disease, and how do we treat it? Well, it's the myeloma that's causing it. So following on from this gentleman's question, then get on top of the myeloma. So treat the myeloma to treat the myeloma bone disease. Radiotherapy is very good for treating sort of hot spots of focal disease in bones, and it can reduce the pain. We may be having to do some orthopedic surgery to do a new hip or fix or put a plate in. We've had a run of collarbones at RPA recently. We've had a good few collarbones reconstructed recently that have had myeloma bone disease. Give patients bisphosphonates, which are bone strengtheners, and the classes, the common drugs are listed there for you. There's a procedure called Vertebroplasty. Has anybody heard of that? Have you had it? 3. This lady's had 3 vertebroplasties. Have you had one as well? Yeah, so vertebroplasty is a process where if you do have a deposit in your vertebra, very painful, it can cause a fracture, there's a procedure of actually injecting some surgical cement into that vertebra that stabilizes the vertebra, hopefully reduces the pain significantly, and that is done by an intervention radiologist, and I've seen good success with that happening. Fabulous, says the lady. So, and it needs to be done by somebody that's used to doing it. Did you have good success with yours? Yes. You still get some pain, yes. And is it better than it was? So, yeah. Yes, yeah, but you perhaps could develop a tolerance to it, yes. So generally speaking, it's done with the aim of improving pain. and not just improving a picture on your X-ray. Yes.
It was the first time at Minimal that they'd done it, and they did 2 at once.
Did they?
And they were very thrilled, and so was I.
Oh, well done. You're a very brave lady.
So I can tell the difference between not being able to walk and being able
Exactly.
to walk is amazing.
Yes, yes. And what a great success story for them to go on and a learning experience for them.
3 months later.
Yeah, yeah. I was talking to that gentleman at the back at coffee, and he was saying that one thing you don't want to hear your doctor say is whoops. And he was having a procedure, and he heard whoops, and he thought, gosh, that's not something I want to hear, but I'm glad you didn't hear that.
With the Vertebroplasty, you have to stay awake because of the nearness to your spine.
Yes.
And pains down your leg. So you hear everything they say.
Yes. Did they say
That's
whoops?
far more than whoops.
Oh, gosh.
Hang on a minute.
Yes. It was their first time. Yes, yes.
It really was their first time. Take photos.
Yes, fantastic. No, don't put it there. More to the left, more to the right. Yes. There is a reason why we anaesthetise you most of the time when we're doing these things.
There has to be a new class in teaching doctors what
Yes.
not to say when their patients are awake.
Yes. Well, doctors have this saying of what is it? View one, do one, teach one, which is how you these procedures. So he'll be teaching it next time round. So vertebroplasty is a good intervention for managing bone pain in the vertebra if it works, of course. Good pain control, weight-bearing exercise. If you're not, I was told a statistic the other day that an astronaut loses 10% of their bone marrow density when they go on an expedition into space because they're not having any weight-bearing with the lack of gravity. So weight-bearing exercise is a really good strategy for improving bone density and bone health. Again, the balance is if you have areas that are at risk, you don't want to be, playing contact sport and fracturing things. But walking, on bicycling, as long as you don't fall off the bicycle, are all good things to get weight-bearing exercise to improve your bone strength, and something you can do to help yourself. And the gentleman already alluded to, should we take calcium for bone health? And in some areas, vitamin D is certainly recommended as a good supplement to take to protect your bones. But do flag that up to your specialist, because there may be good reason why you shouldn't be taking that. Has anybody heard of osteonecrosis of the jaw? Yes. Has anybody had osteonecrosis of the jaw? No. Good. Now, this is a rare complication. We did have an update at the conference that the incidence of this occurring is actually lower than we originally thought. So it's probably only about a 1 to 5%, but it is related to people that are on long-term bone strengtheners. And osteonecrosis of the jaw is where you can have exposure of the jawbone, which then can be quite painful. It can get infected, and it certainly can take a long time to heal. And it seems to be related to people on long-term intravenous bisphosphonates, including people with severe osteoporosis that have been on bisphosphonates as well. It's not just related to myeloma. Increased risk of getting it seems to be if you have poor periodontal health, if you have a tooth pulled, so intervention from a dentist, or they have exposure of the jaw. The longer that you're on intravenous bisphosphonates, the risk goes up, but doesn't go higher than 1 to 5%. I'm just saying that's where the risk lies. Or if you've had radiation to the head and neck, that can also increase the likelihood of getting it. So it is something you need to be aware of, and if you do have any pains in your jaw, or if you go to the dentist and or have any suspicion of having it, you need to flag it up to your specialist. But nevertheless, the balance again, you do need to have bone strengtheners. If you didn't, you'd have far more problems with your bones generally than you would with the low level risk of getting this. There are a variety of, this is what it looks like. You can't really see these very well, but there's a little, this is the teeth here with a nice gold filling, and this is a little bit of exposed jaw underneath here, and the same there. And if you did an X-ray, you can show some bone loss on an OPG X-ray. So it is something, the positive spin of it is it's all made us look at dental health more. We do recommend that patients go and see their dentist before they start bisphosphonate therapy, and that you have regular, as we all should. And as the daughter of parents who are dentists, I should advocate that. Go and see your dentist every 6 months to a year to make sure that you are preventing any problems and not having to treat problems that come about because you've not been looking after your periodontal health. If you do have this, then the way we manage it would be to pull back on your bisphosphonates and allow the dentist to manage the ONJ or to do the tooth extraction that may be required that puts you at risk of it. You may recommend some antibacterial mouthwashes and might need some antibiotics. There are guidelines on these, and I'd be very happy to send anybody them if they want to take them to their dentist who's looking at your mouth. Yeah.
Can I just ask about the half-life of the bisphosphonates?
The half-life, yeah,
last quite a long time.
They do, and but the difference, the half-life of the bisphosphonate, 50% is taken up by the bone and 50% is excreted by the kidney. You will find after one dose of bisphosphonate, you can find bisphosphonate in a person who's had a bisphosphonate, but a presence of a bisphosphonate in your body and that agent, that drug actually having a protective mechanism are two different things. So the fact that your bisphosphonate can be maintained in your body for up to 15 years doesn't mean you just need one dose of it. It's not, it would be subtherapeutic. So the general recommendation is that you have a bisphosphonate for 1 year, all patients having active treatment, and then you risk stratify. So those patients that don't particularly have bony disease with their myeloma may actually either come off bisphosphonates then or have a reduced frequency of their bisphosphonate. Those that do have active bone disease need to carry on for a little bit longer, and if somebody has dental work, you come off the bisphosphonate. If somebody is unfortunate enough to get ONJ, then we come off the bisphosphonate as well. Always weighing up the benefit of, if you don't have it, getting further bone disease and the risk of this toxicity. So generally the recommendation is that you need a year's worth of monthly intravenous bisphosphonate to get the protection that you require. But yes, the drug actually actively remains in your body for up to 15 years, but it's not necessarily protective. Yeah. And these are guidelines I was recommending, and I'm happy to flick them to you, and you can pass them on to your dentist or keep them for yourself. It can recover, and in about 50% of cases it will recover, and 50% of cases it may recover and then appear again. So it is something you want to minimise your risk of getting. I had one case last week actually. It'll be interesting to follow him and see what happens. But it's very uncommon to happen spontaneously. You usually need to have a few risk factors. The longer you're on bisphosphonates, the risk goes up a little bit, but the greatest risk is having intervention from your dentist that exposes jaw. So the biggest risk is a tooth extraction whilst on intravenous bisphosphonates for over a year. Okay, and that's why it's good to get your teeth sorted out at the beginning so that you can prevent the risk of having to have an extraction in the future. In terms of things that you can do yourself, as I said, exercise is good, potential supplements of vitamin D and calcium. Be aware, those of you that know where they have particular at-risk, this lady with your vertebra, etc. There are things you probably know to avoid doing. Be very wary of your posture. We shouldn't slouch, we shouldn't cross our legs. Our mothers taught us that, didn't they? Very good reason. It puts stress, it twists the spine. So do be wary of that posture. Things such as, you know, if you do have pain, then positioning, the height of your chair, how you're getting up, where you're doing your washing up. All these little things really can impact. Heat packs, hot water bottles, etc. Things like that, just in the lower back, if that's where your pain is, can be very helpful in managing sort of low-level bone pain.
Is it a fact that psychological stress can add, impact this negatively?
Yeah, good question. Not really. Can psychological state of mind impact? And certainly not bone disease that I'm aware of. No. There is something in the literature around can increased stress put your immune system or you at risk of developing cancers, or your immune system, can it suppress that? I don't think the evidence is great enough to say that. I have very, very laid-back patients who have the most terrible distress and immune problems, and I have very stressed patients that do as well or don't. So, but there is some areas of interest in looking at that, and can that affect? Certainly, I think effects on how you cope with an illness or health intervention or a diagnosis certainly can. Yeah.